Good afternoon, everyone, and welcome to the meeting of the Leicestershire Health and Wellbeing Board. This meeting is being broadcast live via the YouTube, and it will also be archived so you can view it afterwards. We have apologies for absence from Councillors Cheryl Cashmore, Julia Smith, Sarah Premer, Jean Knight, Andy Williams, Rashna Bias, Harshan Katecha, Ed de Coverley, and Kevin Allen Kimani. Glyn Edwards, Carolyn Trevidic, Kerijit Kaur, and Michelle Howard are in attendance and have stepped in to cover. Thank you.
I think Jane Moore should be here, but she's just travelling back from Derbyshire, so hopefully she'll be here soon.
And I know Mike Sands is running late, so thank you for that. We move on to item 1, the minutes, which is pages 3 to 12. Unless anyone has anything that needs altering or whatever, I propose that the minutes of the meeting held on the 25th of May 2023 are taken as read, confirmed and signed. Are all in agreement with that? Thank you. Item 2, urgent items, there are none. Item 3, declarations of interest. Do any members have any other interests they wish to declare in respect of items on the agenda? No, can't see any. Thank you very much. Item 4, we have my position statement. Copies have already been emailed to you, and a version is also published on the council's website. I don't know if anyone has any questions regarding the update. Quite a lot going on. Thank you. So we'll move on to item 5, which is the Health and Wellbeing Board governance, pages 13 to 14. And this report is to seek the Health and Wellbeing Board's approval for revised terms of reference for the board. Rosemary Whitelaw, Head of Democratic Services, will present this report. Thank you.
Thank you, Chair. I wasn't proposing to say much because I think it's a fairly straightforward paper. Just to say that it arose at the Health and Wellbeing Board development session in July. A representative from Voluntary Action Leicestershire suggested it would be useful for him to become a member of the board to provide some context to issues raised at the board from voluntary and community sector perspective. So the proposal is to add Voluntary Action Leicestershire to the membership of the Health and Wellbeing Board.
Thank you. Are we all happy to approve that? Thank you. Moving on to item 6, the progress report on community health and wellbeing plans. This is pages 15 to 126. The report is to provide the board with an update on the progress of the 7 community health and wellbeing plans across Leicestershire. This report is being presented by Jo Clinton, Head of Strategy and Planning for the LLR Integrated Care Board. Hi, Jo.
Thank you, Chair. Yes, so it's an update on progress against the community health and wellbeing plans, and just to notify the board that we've now had the Melton and Blaby plans approved by their respective partnership boards. So that's 4 plans in total that are now at delivery stage. I'm not going to go through each of the plans because I know we've done that previously. So I wanted to draw the board's attention to page 25 in your packs, and that really it's drawing out the achievements that we've seen in Charnwood area. So I won't go through each of them, but I just thought it was in particular around the mental health priority. So they now have their Syston mental health cafe that's now open, and that's been really well received by residents. And they've also seen an increase in the number of GP practices that are actively accredited from 0 to 6, which basically means they're working with Active together to promote and support physical activity with their patients. So really, really positive. So in terms of the emerging themes, we're still seeing the same themes that we've previously reported on. So that's around improving and supporting access to people of all ages with mental health, the one around unpaid carers, and the other one is around the lack of understanding that we're seeing between partners about the range of services that are on offer to the local population. But we are hoping that with the imminent rollout of the Joy social prescribing app, that we'll see some improvements in that area. So that basically should make referrals much easier. It's a directory of services that's regularly updated, and it will provide us with some really good intelligence around patient numbers and outcomes. The last thing that I just wanted to cover off was around, I know that there'd been concerns from the board around duplication and the priorities and what's happening at a neighbourhood, place and system level. So in Appendix 1, we've set out a table there which basically charts against the priorities that we're seeing coming out of the plans to which subcommittee of the board that we will report into. So I hope that makes it a bit clearer. What we will be doing is, as well as obviously providing our updates here, we will be going to those committees and providing updates to make sure that there is that golden thread between what's happening at neighbourhood, place and system. So I will stop there and I'm happy to take some questions. Thank you.
Any questions? I just have one. You've mentioned, Jo, about where you're feeding information in, etc. When we have the similar things coming up in each area, how is that being fed in and out of place to ensure that what's being done at place as a whole, if you know what I mean, is not duplicating, or things going on in neighbourhood are not duplicating? Just so that you talk about the golden thread, but where do we see something that should be done at place level, which may be less costly, or, how do we tie those things up? Thanks.
So that the reporting into the subcommittees is a very early stage. We've already started reporting into the Staying Healthy Partnership. I think that's where the discussions need to happen at those committees, so that we report on saying that we're seeing this at a neighbourhood level, what's happening at place, so that we know not to duplicate efforts in the neighbourhood, or is there something else that we can be doing to complement it? So it's very early days to give you sort of solid stuff. I'll make sure that the next time round that we start pulling a bit more out of that for you.
So you would expect that to come up from those subgroups into the Health and Wellbeing Board?
Yes. Yeah.
Okay. Thank you. Anyone else have any questions? No. So we've just been asked.
I had a question. Sorry, Louise.
Sorry,
Louise. No, that's okay.
Go
I was
ahead.
just going to feed in from an integration perspective, and I've taken you to just answering that previous question on how we link some of those community health plans. So for any of those things that are commonalities against all of those locality plans, Jo will tell you that as part of our integration work, we are pulling that together where there is elements of work between health, social care, public health, etc., as part of our IDG, which is one of the subgroups of our integration exec. And I think I've taken yourself through it before, Louise, how we're just in the process of bringing together all of those commonalities so that we've got an across the board plan that will complement some of those locality plans. And my team and the wider integration delivery group are working with Jo's team to bring that together into what that might look like as a whole. Just to add to what Jo was saying.
Thanks. Appreciate that, Lisa. And sorry I missed you. I can't see anybody else. So we're just being asked to note the progress. So thanks, Jo, for coming along. Appreciate that. We're now going to move on to item 7, which is the Better Care Fund Q2 report, pages 127 to 136. We did have a document missing, so I have asked if Lisa, who is the Integration Service Manager at Leicestershire County Council, if she'll present this report, perhaps show the paper that we should have had in the documentation. Thanks, Lisa.
Okay, what I'll do then, instead of seeing me on the screen, I shall share what that looked like that went out to you just before the meeting, and I'm just going to take you through it. I keep getting this pop up, it's very annoying. It'll only happen twice. There we go. So the report that you received that goes alongside this is obviously taking you through this document here. I'm just going to go back to that report. So hopefully you can still see the spreadsheet on the screen as being shared? Yep, I can
Yes,
see it from
thank
here
you.
actually. So what we've had for Q2, we haven't had quarterly reports for the last 2 years through BCF, and they've done the first one as a Q2 report for this 2-year plan for the BCF. You'll notice, well, you may have noticed, but in that spreadsheet, there isn't any financial planning as yet as part of the return. That apparently is going to be fed into Q3 and Q4. This spreadsheet predominantly is about us doing a refresh of our demand and capacity modelling that went as part of the original plan in June 2023, which was approved by yourselves and came to the Health and Wellbeing Board as a draft. So really what we're doing here is asking the Health and Wellbeing Board to look at this, which is essentially the Q2 draft. It is due to go today, but at time of writing the papers it was just a draft. There have been subsequently a couple of changes, but I'll get to those in a second. So the template consists of various different tabs, and I'll just take you through those tabs. We've got a cover report, which is essentially double checking to make sure you've completed everything. It's got the contact details, etc. These are our national conditions. So as you can see here, we've got 4 national conditions that the BCF has to apply to. It has to be a jointly agreed plan, which we've done. It has to implement the policy objective number 1, which is enabling people to stay safe, safe and independent at home for longer. Objective 2, providing the right care in the right place at the right time, and maintaining NHS's contribution to adult social care investment and any NHS services commissioned out of hospital. So all of those 4 are still being adhered to. The next tab is around metrics and gives you an update on our progress in year on where we are with those metrics. So there are 4 key metrics. I'm just going to make it a little bit smaller so you can see it online. So we've got the only metric that we're not on track to meet the target for is the avoidable admissions. I have had my BA double check that figure because it is quite higher than normal. Usually it does come down a bit because an in-year figure isn't particularly aligned to the population data, so we do have to it is per 100,000 population, so it does come down a bit once we've had the population data for this year published, which will be sort of around June next year. However, it is still higher than we would anticipate, so that means we're having more unplanned hospitalizations. We are on track to meet the other targets, so discharge to normal place of residence, admissions due to falls, residential admissions and reablement. We're all still on track to meet those targets that we published in our June BCF plan. This is around the guidance and assumptions to the demand and capacity modelling and how these might have changed over time. So what they asked us to do is to look at the first 6 months of our year and say, do you feel like the demand and capacity model that you completed as part of the BCF that was submitted in June, do you feel that that is still relevant, or do you have any changes to that data? In those changes, we do have to make some of those assumptions. So, for example, if from April to the end of September, we've seen a large reduction in the use of D2A residential care beds, we might have to caveat that it might not be a continued reduction at that rate because of, winter pressures and the fact that you have more demand over the winter months. So all of that is detailed in these assumptions here that go alongside the demand and the capacity. That is split into 2. So you have hospital demand and hospital capacity. So that is around when you're discharging people. And then you have community demand and community capacity. So that is where the persons largely step up as part of an intermediate care model. So that is there to kind of describe some of the data and some of the changes that we have made. Since this was originally published, we have had refresh data for our step up urgent care response demand, which I have inputted, but obviously doesn't form part of this paper because the caveat was that some of it may change. We've also had a couple of changes to the comments in the metrics as well, but we can make sure you get an up-to-date copy of this as and when it's published, which will be as soon as I've had agreement from you in about 5 minutes' time. As you can see here, this is where it splits the capacities and demand. So this is the hospital discharge page. This is the community capacity and demand that you can see here. They've done these blue boxes here can't be changed. So what they've done is they've pre-populated it and frozen those cells so that we can see where there might be any plus or minus any changes to that. So that's taking you through that spreadsheet that we're going to send to the NHS England today, as today is the deadline. I don't think there's anything else to update you as far as that's concerned. As I said, there was just the 2 changes that we've made, but we will make sure you get an up-to-date copy.
Thank you, Lisa, and thanks for taking everyone through that. Does anyone have any questions on the BCF? I think it's jolly good that we're maintaining target on everything bar that one that you mentioned.
Yeah, and interestingly, Louise, just to come in, that we've seen a huge increase also in the amount of demand going into our urgent care coordination hub. So that has in effect doubled from when we did that first return in June, which was based on the previous year's figures. We weren't quite sure whether there would be an increase or a decrease, so we kind of said we project it's going to be roughly the same as last year. It isn't. So we've actually had a lot more demand go into that care coordination hub, which is, you know, where we take all of the things off the ambulance, the EMAS stack, and we can deal with people in the community using therapy resource and adult social care resource. So we've still seen a huge increase in that demand, but also that increase in people still being admitted to hospital. So there is more work to do there, but we have it's always going faster than we can increase our capacity.
Yes, yeah. And I mean, are we looking into why that increase has come about? Are we going to be doing any, checks on why that's happened?
Yeah, so we will, as part of that urgent care response. I mean, we're still meeting 93% of the time. Yeah. We are meeting those 2-hour targets, so we're not missing any of that cohort. So it might be that actually it isn't necessarily about it might be that we instead increase the demand and the cohorts going into that urgent care coordination hub further, because even though we've had that increased demand, our performance hasn't worsened. 93% within the 2 hours is still really good. So is there more that we can do to ensure that people that are presenting at hospital are being seen by that care coordination hub, because actually that's the better offer to remain them in the community, to get therapy and get all the resources they need there. So it might be that we extend that even further to make sure that especially through winter we're seeing fewer unplanned admissions. But yeah, as far as we know,
to cope.
Yeah, as far as we know, we don't have any solid data as to why that might be in terms of condition specific, e.g. COVID, flu, etc. And as I said, that figure is normally very out in year because we haven't got the up-to-date population data.
Okay, thank you. I can't see anyone wanting to ask any questions. So we've been asked to note the performance against the outcome metrics and the positive progress made, and also to approve the submission to the NHS England. So we're all happy for that? Yes, thank you. You can submit it now, Lisa.
Thanks very much.
Was that 5 minutes?
Cheers, bye. Thank
all. You. Bye. Item 8 now is the Joint Strategic Needs Assessment Update, proposed process and governance, which is pages 137 to 144. This is providing us with an update on the JSNA chapter delivery and proposals on the governance and process by which the chapters within the JSNA cycle are prioritised and agreed. And we have Andy Brown from Business Intelligence Team Leader at Leicestershire County Council will present the report. Thanks.
Thank you, Chair. Yes, I think you captured very well the purpose of the report today. We wanted to bring you an update on the progress of the JSNA itself in terms of the chapters that have been delivered and the outstanding areas that are due to come through to you in the coming months. And also to bring a proposal around the governance and process by which we produce chapters, just to make sure it's fully aligned with both the board's priorities, but also agencies' planning and commissioning strategies, because there's a real art to make sure we're maximising the impact of our sort of small-scale evidence and intelligence resources and getting the timing right, just to make sure information is coming through at the right time for you. So in terms of the JSNA, you're all familiar with the JSNA and its purpose, so I won't go through the sort of statutory requirements around JSNAs. We've set out in paragraph 14 progress so far. As you know, we had a bit of a hiatus through COVID when we had to prioritise our intelligence resources towards COVID, but over the last 12 months or so, we've been able to start picking up the evidence base again. We've particularly had the release of the census information.
Andy, sorry, could you just go through that, because I'm not sure everybody will be okay with that.
Okay.
Thank you. Sorry.
Yeah, okay, that's fine. Yeah, sorry, I was making the assumption that you'd be familiar with that. So the JSNA is a statutory requirement. It's on the Health and Wellbeing Board itself to lead, oversee and manage the JSNA and the products from it, and make sure it's useful and producing recommendations that reflect the needs of the population and are properly evidence-based. Properly bought into by all the agencies of the board, and it takes forward the health and wellbeing strategy and the wider priorities of both the ICS, ICB and the County Council and partners. So it is very much a structured process. So we have got flexibility around the look and feel of it in terms of the size of the different individual chapters, the amount we do via dashboards, the amount we do by survey work, etc. Having said that, we have some established protocols around the document that has proved useful to us in the past. So the board has agreed that you'll get service sort of subject specific thematic chapters looking at particular topics in a more detailed level, working through the relevant boards and support groups and partners to make sure those sort of are evidence-based pieces of work with proper buy-in and really informed recommendations. But then for other areas of work which are less priority, don't need the big sort of pieces of work, that we do more of those through more sort of shorter targeted piece of work, looking at the data as it's refreshed using dashboards, etc. So there's a little bit of flexibility around how we deploy resource depending on the topic and the priority that's given to it. And then we've got quite a range of dashboards and intelligence that's flowing now, both in terms of County Council and public health intelligence, but we work very closely with partner agencies through the data cell. So we're accessing a lot of information on a sort of anonymised, confidential basis, summarised level information around the wider health system. And we're getting more and more intelligence feeds all the time that can feed through into the JSNA process. So there is statutory guidance, established protocols around that. And we used to have a steering group prior to COVID that was really helpful to us in helping shape the timescales, the priorities, getting the right people to feed into the individual chapter design to make sure that we are hitting the right planning and commissioning cycles and have got the right level of buy-in from partners to the topics. So in paragraph 14, we've set out the current progress. So we've had some big chapters already agreed, like health inequalities, children and people's mental health. 2 more chapters to come to you in a moment on demographics. And we've had a lot of data released over the last 12 months around the census, which is real overarching information that feeds into the rest of the chapters. So it means we can now start to feed that in. And also the important area of dentistry and oral health. So they're to come through next. We've got a big piece of work around adult mental health that's underway. So that'll be coming through to you as part of the next cycle. End of life care is complete. Air quality is underway. Carers is making good progress. and then also some work around sexual health, which is a health and needs assessment rather than a JSNA. So some big pieces of work have been completed, some more are well underway, and we're coming through to you shortly. So we've got 2 items next, and then the batch of theme areas on the right hand side of the table, which we really want the steering group to help prioritise, shape. Some of those may stand out as big pieces of work to do earlier, some maybe more targeted, shorter data pieces of work, and some maybe lower priority, and some may align better to agency planning commission cycles at different phases than others. So we would like to establish the steering group again. We set out in Appendix A the proposed terms of reference and membership of that group, very similar terms of reference to the previous group, so nothing significantly changed in terms of the role of the group. We've suggested a few names where we know there's been a lot of change in the system, a lot of change in roles, etc. So we've refreshed some of the names, but we're very happy to take alternative names if we haven't got it quite right. So if there's people that fit better with this process, we're happy to take names, and we'll be coming out just to confirm whether we've got the right names on there. But hopefully that's a really good selection of across the agencies and across the different themes representation to help shape the next phase. I think that's all I want to say by way of introduction, but I'm happy to take any questions or comments about sort of the process and next stages.
Thank you, Andy. Anyone have any questions for Andy? Yes, Mike.
Yes, thanks, Andy. I mean, I think you're right. We need to get a sort of steering group back up and running again, because that was useful before. Any chapters we do, I guess, have got to be useful to the Health and Wellbeing Board, because the other bit of purpose is to provide information to be used by commissioners or whatever the choice of words is. Looking at the column on the right, I mean, I'm open to suggestion about the best way of theming it. I was thinking we need to make certain the chapters that come through reflect the life course approach in the health and wellbeing strategy and the cross-cutting themes. So it kind of lends itself to the ones labelled children, young people's health, what else have we got in there? Frailty in older people from the point of view of kind of living well and independent. So I don't know if looking at the chapter looking at the Health and Wellbeing Board kind of subheadings helps kind of, if you're looking for a priority within the ones on the right, just kind of pick the ones that look like they're most relevant to either the health and wellbeing strategy or the subgroups. But then I thought it could be actually what the subgroups are working on might be individual bits within that. So I'll sort of slightly contradict myself by going, it's always worthwhile going out to the subgroup chairs going, what do you think is coming through your work plan? Because again, the chapters should tally with work that is deemed necessary, if you like.
Anyone else? No. So we're being asked to note the progress on the JSNA's chapters to date and the current planned list of future chapters. Approve the re-establishment, terms of reference and membership of the JSNA Oversight Reference Group and proposed governance arrangements. And I do agree that I think that steering group will be very useful. Ask the reference group to review and discuss the current list of chapters and scheduled within the cycle to 2025 and bring back any suggested changes or additions to the board for approval. And to receive and consider future JSNA chapters as they become available, including any progress updates on the recommendations highlighted within the JSNA. Are all happy to agree those?
Yep.
That's brilliant. Thank you, Andy. Our next report is the Joint Strategic Needs Assessment chapters, Demography and Oral Health, pages 145 to 168. This report is to provide the Health and Wellbeing Board with a summary of the headlines, conclusions and recommendations arising from 2 recent JSNA chapters developed on Leicestershire's demography and on oral health. Andy Brown and Richard Wilding, Business Intelligence Team leaders, and Luke Cleaver, Senior Health Improvement Officer, Leicestershire County Council, will present this report. Thank you.
Yes, just a few short words by way of introduction before handing over to Richard, particularly to take us through the demographic chapter. As mentioned in the previous item, two really important chapters have come forward to you today. One more, an overarching chapter with the demographic themes and trends and some really interesting information that's come through over the last few months that we've been avidly diving into and matching it with other data sources, etc., to really try and understand the sort of post-COVID environment using the census information. And some, as I say, some really interesting items within there. Richard Wilding, my colleague, leads the County Council's work on demography and census. He's helped put this chapter together, particularly with Victoria Rice, who leads our public health intelligence work. So they're able to sort of pick up any particular comments on some of the detail in the document. Richard just got a few slides just to try and help you sort of find your way through it. I'm conscious there's a lot of information in there. A lot to sort of process. But if Richard, you want to just sort of pull out a few of the key points, that'd be helpful.
Sure. Got a few slides. Oh, thanks. If I crack on, I've got a few slides which pull out some of the headlines from the demography chapter. So first up, in terms of demographics, the census revealed a 9.5% increase in the county population since 2011. That was well above the national average increase of 6.6%. 5 of our districts had above national average growth, while Melton and Oby and Wigston's growth rates were quite a bit lower. The chart on the screen in front of you shows the population structure at the time of the census in 2021, with the percentage in each age band by gender. The grey lines show the England average, and if we compare to this, we can see that there were more over 50s in the county population and fewer people in younger age groups. The one exception to that is those aged 15 to 19. And I think that's accounted for by student populations in part of the county that sort of boost that age group. In terms of projected growth in future, projected population increase over the next 20 years, it's projected that the population will go up by 23%. That's 162,000 people, taking the county's population up to 860,000 in total. This does vary a lot by district. So, for example, in Northwest Leicestershire, we're projecting, or the ONS are projecting, a 34% growth rate. In other parts of the county, such as Melton and Oby and Wigston, there's much lower rates of growth projected. The chart on the screen shows the projected growth rate by 5-year age groups. The greatest increases are projected to take place in the 65 plus age bands, and people aged 65 plus, we're expecting to see an additional 72,000 people in those age groups. In terms of where that growth is coming from, the county will see negative net natural change. So that's births minus deaths from 2031 onwards. And the main components of growth over this period will be internal migration, so from elsewhere in the country. That accounts to about between 4,500 and 6,500 people a year moving into the county from elsewhere in England. We will also, or projected to see, relatively low levels of international migration, so below 1,000 a year, but that will make up part of the growth that we're projected to see. In terms of mortality and healthy life, age standardised mortality rates for main age groups were significantly lower than national rates. Rates of premature mortality, again, they're significantly lower than national averages. About a quarter of deaths in the county are due to cancer, or were in 2020. That is significantly above the national average. Just under 22% of deaths were due to circulatory disease. That significantly declined over the recent years. In terms of place of death, I've got some figures up there on the screen. So just under 41% of deaths were in hospital, followed by 33% at home. Those broadly reflect national patterns. One point to note on this slide, healthy life expectancy at birth for males has decreased year on year over the last 3 data points that we've got on this, from just over 65 years to 62.9 years. So that is a point to note, and perhaps something that's well worthy of further investigation. Last point on here, 16.5% of our population had a condition that limited day-to-day activities, and that is slightly below the England average for that particular statistic. In terms of protected characteristics and our population, 12.5% of the county population is from an ethnic minority background. This is lower than the national rate of 19%. A very different position over the border in the city, as you'd probably imagine from the county area. Having said that, rates of ethnic minority populations vary very significantly by district. So, for example, Oby and Wigston, just under 37% of the population there is from an ethnic minority background. Largest group of ethnic minority peoples are Asian or Asian British. That makes up 8.2% of our population, and around 58,000 people falling into that group. I've got a few stats there in relation to religion. One interesting thing that came out of the last census, 45.7% of people identify as Christian. That's down from 60% in 2011. So quite a significant drop there over the last 10 years, and a corresponding increase in people saying that they have no religion. We've got 61 recognised gypsy and traveller sites in the county, counting for around 500 families. Significant numbers of this minority group do live in bricks and mortar housing, estimated to be about 2,500 to 4,000 individuals falling into that category in addition. Those identifying as gypsy or Irish traveller have significantly worse health outcomes and are much more likely to report bad health than the wider population. There's been a recent report based on the census that's come out from the ONS, which backs that up and looks at their outcomes across a range of different factors. Next up, deprivation. So the index of multiple deprivation that's produced by government uses 39 different indicators which are grouped into 7 themes. Leicestershire is ranked 137th out of 152 upper tier authorities for multiple deprivation, where 1 is the most deprived. So we don't stand out as being deprived in really any shape or form compared to other areas. Having said that, around 12,000 people within the county do live in neighbourhoods that are rated as the 20% most deprived in England, and they are broadly in areas of Loughborough, Colville and Hinckley. And this chart, which I appreciate is slightly complicated, it shows the number of residents estimated to fall into each national deprivation decile by theme. The most deprived deciles are shown to the left in deeper purple. And looked at on a theme basis, there are some pockets of deprivation under particular themes. So I draw your attention to education and skills, which is about halfway down, and we've got 81,000 people who are estimated to live in the most deprived 20% of neighbourhoods in relation to education and skills. This looks at lack of attainment and skills in the population. And one other that I'd point out also is barriers to housing and services, 1 up from the bottom. This measures physical and financial accessibility of housing and local services, and we've got an estimated 57,000 people that fall into the most deprived 20% of neighbourhoods in that grouping. We've got a little bit in here, summary in terms of businesses, employment and skills. So largest employment sectors in the county are manufacturing, followed by professional, scientific and technical job groups. One area that's seen a big increase, particularly over the sort of pandemic period, is transport and storage jobs. So we've had something of a logistics boom in the county, and about a third increase in jobs in that sector. Employment in health has actually gone up as well since 2019. Residents of the county are more likely to work in managerial and professional occupations compared to other East Midlands residents. And we do have a higher proportion of people that are qualified at NVQ levels 1, 2 and 3, so that's up to A-level standard, but slightly fewer or a slightly lower percentage of people that have got degree level qualifications in the county. So to start to wrap up really in terms of implications of what I've said, I think key things perhaps for the board to consider are continuing to plan for the increases in the elderly population that are projected. I think here things like workforce planning, capacity of services, supported accommodation, adult social care, dementia services, all to the fore. I think one flip side of the increase or a particular positive from the increase in the older population is that there'll be a greater pool of people there that perhaps we can draw on to aid sort of volunteering and community activities. This particular group are very good often at volunteering, so there are things that we can draw on in that sense. Need to understand and tackle drivers of lower healthy life expectancy among men, which has come out as a particular trend and issue. Need to be mindful of rural disadvantage and isolation, as well as some of the higher deprivation neighbourhoods that we've got. And also need to consider health implications of the changing economic landscape and working patterns. So in terms of recommendations up there on the screen, and I think this reflects some of the items that are down there in the report. So really taking the issues into account in future planning, considering the implications of the chapter via the board's subgroups, consideration of a deep dive to examine factors behind the fall in healthy life expectancy in males, and also noting that work around health inequalities is picking up some of these issues, and that some of those are pulled out in the health inequalities JSNA chapter that I think has already been considered. So I'll stop there, but very happy to hear any comments or try to answer any questions.
Thank you very much. Really interesting, but some sobering information coming out of that JSNA. Has anybody got any? Yes, Ms. Radford.
It's not so much a question. Is it possible to have a copy of that slide, or is it information? Because I found it very interesting to, with my adult thing on about, what we've got to look at in the future.
Yes, absolutely. Yes.
Lovely, thank you.
Yeah, thanks, Chair, and thanks, Richard. Yeah, I mean, like Mrs. Radford would say, that we all need to go away and sort of digest that. It's more of a question for all of us rather than for you in terms of making certain we're using it in our commissioning decisions and the subgroup work. And I don't know if there's a question for you or not, Richard, but when I'm putting sort of those last points together, so we kind of get used to going, oh, there's going to be an increased number of older people and we need to take, and we do. But then coming back to the point about healthy life expectancy, well, why it's going down, we can make a punt, is because people have got more long-term conditions than they used to, and it's limiting their ability to live healthy lives for longer. Put the two together, I suppose the next bit is a kind of economic stroke demand modelling in terms of what does increased numbers of older people who've got more complex needs mean for capacity for adult social care, and the cost of using them. So whether that sits with you and Andy and Victoria and colleagues to do the modelling, or whether we go away and try and think some sort of more technical questions, if you like, is one that we need to consider. But I'd be interested from your point of view. Have we got the capacity? Well, we got the capacity and capability, because it's a tough ask to actually take that data and really model it through into kind of like, this is what Leicestershire's challenges are going to be in the year 2035, and it's going to cost us this much extra to deal with this many people with more complex care needs.
I'm sure we can work together to sort of scope this out. I know the ONS is continuing to release sort of more and more tools and analysis based on the census, which will hopefully help us to do that. I mean, I think hopefully there'll be some nationally provided tools that will help us to sort of start to sort of work down that route. But we can certainly work to sort of scope out what needs to be done and think about how best to do it.
Yeah, there's clearly a lot of work going on in adult social care, particularly at the moment, looking at demand impacts of the post-COVID environment. Obviously, they're getting considerable demand coming through at the moment, and very interested in sort of forward thinking that, particularly over the sort of the short to medium term, obviously also in the long term. So there is also data, more operational data that we can draw on. And try and sort of extrapolate that moving forward. So I'm sure with the adult social care team, we can certainly look at that.
Yeah, thanks both. And then the other one for me was the other end of the age spectrum in children. So I get it right. So we've got a higher percentage than the national average that have got A levels, but then a lower percentage that have got a degree.
Yeah, that's correct. We tend to have higher levels of people with basic skills or up to NVQ3, which is approximately A level, but then we do have a lower proportion of people with degrees.
Yeah, and because of my learned colleague. Why is that then?
I think it's a population issue. So it's about the numbers of universities and where young people settle, isn't it? Post-university. So it'll be related to the number of universities we have in Leicestershire, compared to the number of children that leave Leicestershire to go to university and then don't return with their said degrees.
Of course. So we educate them well, and then they disappear, go get a degree, and then they stay put in their area where they've gone.
Yeah, because we've only got one university in Leicestershire.
Yeah.
And they may not stay. So it's about the input and output of universities and where they go to after they've done the degree. So Loughborough clearly aren't very good at holding on to people, would be my summary of myself.
Or I suppose it's whether it's a mini version of Rutland where everybody does that, they go away, but then they come back later. So I suppose the other bit is, can we track them to see if they do come back once they start having families?
I've got other things that I might be focusing on.
Oh, well, no, because they pay tax and they haven't got problems. That's fine. Get them back.
Michelle.
Apologies. Just wanted to comment also on the importance of through perhaps those plans or at a local level being able to feed through some of the real-time population changes. So, for example, we know there'll be an awful lot of resettlement activity, asylum dispersal activity, and that will change the dynamics somewhat. So, just being able to make sure that we keep a close eye on that and it's continually informing that chapter would be helpful.
Thank you. I think we've really got to be, check we're prepared for what's coming really and the pressures on the services. And there's a question about whether we have enough preventative measures in place to target, 40 plus now to mitigate the impact further down the line. As with all health issues, there's always a time lag, and we've got to make sure we don't have even more pressures on services like adults and social care. Thank you. So any other questions? No, can't see any on the screen. So we're being asked to support the findings and recommendations of the Demography Joint Strategic Needs Assessment chapter and approve the chapter for publication. All in favour? Yes, thank you. Ask the strategic planners and commissioners to consider the various demographic changes, trends and issues arising and ensure they're taken into consideration where possible in future service and commissioning plans and strategies. And oral, yes, I'm just coming to that. We're now going on to the JSNA of the oral health chapter. Thank you.
Hello, everybody. Thank you for your time today. My name's Luke. I'm a Senior Health Improvement Officer here at Leicestershire County Council, and as a part of my role is I lead the oral health team within the county. So today I'm here to talk you through the Joint Strategic Needs Assessment. We had a large working group that we pulled together to complete this work, so it spanned the integrated care system, so NHS England, Integrated Care Board, voluntary community sector. We also had key representatives of those vulnerable groups across the community who we know, which we'll go through today, are at increased risk of having poor oral health. So we did this JSNA on behalf of the Health and Wellbeing Board, and there's two key questions for us today that we'd like your support in answering. So the first one is, provided of course that you agree, how would you like us to proceed with the recommendations? And we'll go into those at the end of the presentation. And then secondly, how would you like to be kept up to date with ongoing developments? So we do have one slide, a simple slide about some proposed governance structure to help draw some clear lines of accountability. So in this presentation, we're going to cover who is at risk, the lifestyle factors in relation to Leicestershire and how they affect oral health, the health inequalities within our child and also adult population. Also going to touch on access to dentistry because we know that's a national issue. We're going to touch on the workforce shortages for oral health and dentistry and look at some of the central government responses to what is a national issue. Then we'll cover recommendations before moving on to the governance, and I'll be happy to answer any questions. It is a big document, so I can't cover all the points in this presentation. However, if there are any bits that you feel I've missed or you'd like to discuss further, I'm more than happy to answer any questions. So who is at risk? If we do a bit of a deep dive into children specifically, we have two surveys that are done nationally, but we have them for Leicestershire, one for 3-year-olds and one for 5-year-olds. So for our 3-year-olds, almost 11%, so let's say 1 in 10 children aged 3 had already experienced tooth decay. Now this doubles by the time you get to age 5. Okay, so already you get 1 in 5 experience tooth decay, or 2 in 10 already experienced tooth decay at age 5. So that's particularly concerning. When we look at our 3-year-olds, what we find is when we break that down by ethnic background, the other category, which we don't quite know what's packed into the other category, but what we know is that 21% of those 3-year-olds have already had experience of tooth decay. And for our Asian and Asian British residents, 18.4% have already had experience of tooth decay by age 3. So when we're planning our public health interventions, there's a particular need to work together with those residents to resolve those issues in those groups in particular. Children are twice as likely to experience tooth decay in the most deprived areas versus the least deprived, and they're 3 times more likely to have a tooth extracted living in the most deprived area versus if they were to live in the least deprived area. So these are big gaps in health inequalities. In relation to tooth extractions, they're the number one reason, so they're leading cause of hospital admissions and children having to undergo general anaesthetic between the ages of 6 and 10. And if we just think what's behind that, there's some sleepless nights, some time off school, mum, dad or carer is going to have some time off work to take them to these appointments. So the impacts of tooth extraction alone are vast. Final area I'd like to draw your attention to for the children population. I'm going to talk about some 2021 data, which is slightly old, but I'll explain why. So 28% of children from 2020 to 2021 had their teeth checked by a dentist who were classed as looked after children or children in care. Now, our rates used to be 88%. So there's a concern there. And when we compared that to our statistical neighbours, so they're areas that have the similar demographics and population size to us, we found that their average was 45%. So even though the pandemic did hit our statistical neighbours as it did us, our rates dropped down worse. So we're now doing some work to explore why they are. We're looking into some of the pathways and trying to improve on those to support those children. If we move now on to our vulnerable adults, so particularly we'll focus on care homes for this presentation. So the Care Quality Commission, which we'll often refer to as a CQC, they published their Smiling Matters report, and it was on the oral health in care homes. And what they found was that 83% of care homes do an oral health assessment on admission, which is great. However, what they also found was that the detail within these plans varies greatly. So some are very robust, some much less robust. When we explored the reasons why this was the case, what we found was that there was a perceived lack of up-to-date guidance for care homes on how to best look after the oral health of their residents. This was instilling a lack of confidence in our oral health colleagues. There was also some workforce shortages that were cited when we spoke to care home workers and residents. They were saying that's one of the reasons why they tend not to have oral health champions to progress this work. To compound this even further, unfortunately, only 1 in 4 care homes said that they could access a dentist in 2022. So there are some issues, as we'll come on to later in the slides, about about dentistry, access to dentistry issues. When we spoke to dentists about this, what they said was that a lot of messaging goes towards care homes, but their fear is that a lot of messaging also gets lost because so much messaging goes towards that particular group. So within our recommendations, there's some issues there that we hope to address by doing some targeted work with care homes, having the residents at the heart of that work, including the care staff, training care home staff, and we want to do that alongside them with our integrated care system colleagues. We'll touch on just briefly just a few groups, as my colleague touched on Roma Gypsy traveller population earlier. So I have 14% for this slide, but I learned a second ago it's 12.5% report their health as bad or very bad. And we also know that they've got some significant oral health challenges. The particular challenge we face for this population is that we don't have much data behind their oral health. So we would like to survey and work with that population to try to resolve some of those issues. We have the one prison in Leicestershire, in Harborough, Gartree Prison. We know that on admission, there are significant, very high oral health needs in that population. They're 4 times more likely to experience tooth decay, for example. And in terms of our military personnel, although we don't have a base here, we know that those who reside within Leicestershire, about 63% of those in non-officer roles are twice as likely to experience tooth decay, because 63% of them come from the most deprived areas across the United Kingdom, which we thought was quite interesting. So we'll move on. Lifestyle factors are one of the primary issues when it comes to poor oral health. So I've got some data, but what I've tried to do is to actually turn this into some figures for us. So in terms of those who are obese or overweight, at reception age, that's 21.1% of reception children are either obese or overweight as we sit here today. Okay, that goes up to, when they're in year 6, it goes up to 33.2%. And then as we enter 18 plus, it's 64.1%. So the national average is 64%. So we're statistically similar to the national average. But when we break that down into an actual figure of those adults who are obese, which is 26.3%, we find that's 150,000 residents currently within Leicestershire are obese. So that's 150,000 residents within Leicestershire that are increased risk of having poor oral health, because we know that often with weight management that high sugar diets lead to obesity, for example, but they're also increased risk of a lot of other issues like metabolic conditions, Alzheimer's, etc. When we move on to smoking, our rates are quite good, so 11%, and statistically we've got the best rates in the East Midlands. Nationally, we're also doing really well compared to our statistical neighbours. However, it's still 65,450 people who smoke, so practically we felt that was still very significant. That's also a lot of people who are at increased risk of having various mouth cancers, for example. There's a really good survey that goes around primary schools, and what we found from within that survey was that 34% of children reported that they ate 5 fruit or veg a day regularly. However, that's still 66% of children where potentially there's some room for improvement about having a varied and balanced diet, which, as we know, can also positively or negatively impact oral health. And then lastly, there's a virus called the human papillomavirus, or the HPV vaccine is what we're interested in today. This has been an amazing intervention because it's been shown to significantly decrease the risk of different oral cancers. However, whilst we expected, as nationally, we noticed that there was a big drop in everybody's HPV vaccination uptake rates. So we were no different. But what we thought was that we would bounce back, but we haven't quite bounced back at the rate that we hoped we would. We're still in the 70%. So we'd really like to do some work about how to increase those vaccination uptake rates across Leicestershire for those eligible pupil cohorts. The health inequalities that begin within childhood that we've touched on earlier. So, for example, you're 3 times more likely to have a tooth extracted if you live in the most deprived versus the least deprived area. They tend to persist into adulthood, unfortunately. So, for example, in the most deprived area, 25%, okay, so like 1 in 4, so 25% of adults are missing 20 or more teeth, 20 or more natural teeth. If you look at the tooth decay in Leicestershire, at least 1 or more, so about 1 in 4 people are walking around today with 1 or more untreated tooth decay. 14%, which are now known as 12.2% of travelling population, report their health as bad or very bad. So we're now going to switch. Sorry, I can hear myself. So we're now going to switch on to. Apologies, 1 second. Yeah. Oh, brilliant. Yeah, it wasn't muted, it just kept going. Sorry. Sorry, I apologise, that just began to kick in there. So if we turn on to accessing a dentist. So when at the time of doing this joint strategic needs assessment, so this is a snapshot of when we did this data, 40% of dental practices were not taking on any new patients. Okay, 35% were only taking on patients from if another dentist referred them, and 10% were only taking on patients if they were children or young people. So we wanted to understand why this was. So we met with a lot of dentists and we had a lot of task and finish groups to try to understand this problem. The local dental committee kindly agreed to survey all the practices across Leicestershire to get an understanding of some of the challenges they were facing in relation to dental access. And what we found was that 95% of dental practices reported that they were having difficulties recruiting dental staff. 93% reported they were having difficulties recruiting dental nurses. Okay, now 43% of those practice managers within dentists, what they said was that these vacancies were lasting 6 to 12 months, 43% of the time. So that's quite a long time to be without staff. And then 81% of them said that it was negatively impacting on their ability to deliver their NHS contract. So accessing a dentist is a national issue. There have been some things that have been done by central government to try to respond to this issue, and there's a few things locally that we've got within the recommendations that we'd like to pursue. One of the things that they've done is try to have fairer payments for that more complicated dental care. So previously, for example, if it was in band 2, if you were to do one procedure versus another procedure, you would get the same pay. But if one of those procedures is now more complicated, takes longer, then they will get more pay for that. They're also now able to attract dentists from overseas, and there's increased push to get additional training places for dentists, dental therapists and hygiene professionals. All of this is outlined in the NHS long-term workforce plan. So now we're going to touch on the recommendations. So they broadly fit into these 4 headings. So what we'd like to do is, in acknowledgement that these access issues are unlikely to go away anytime soon, we know we've got to work with them, but we'd still like to investigate them in relation to our most vulnerable residents to see how they're being impacted. That includes men of working age. So we've found that they're less likely to visit a dentist compared to their female counterparts, children living in poverty, the elderly. And then we'd also like to survey the Roma, Gypsy and traveller population to try and work with them to assess their needs and respond appropriately. We'll then move on to supporting population groups at risk. So we'd like to do some targeted work for care homes, which we touched on earlier. We'd also like to commission community fluoride varnish across Leicestershire, but you'll notice within the recommendations that there's many of them that says with a backup plan of, and it will list either a specific recommendation or for us to go back to the evidence to look at what we can do, because we want to acknowledge those workforce shortages, but we also don't want to let that stop us doing some of the good work we know we can be doing. In relation to promoting healthy lifestyle choices, we want to consider adding oral health education across our healthy lifestyle services. So, for example, our weight management service, we've seen earlier 150,000 people in Leicestershire are currently obese. So can we add in some oral health messaging, for example, into a service like that? We want to look at ways or explore ways to maintain healthy eating education within our primary schools and our education settings specifically, and consider ways to improve our HPV vaccination uptake. And then finally, we'd like to increase the public understanding. So for everything we do, we have to make sure it's acceptable to the residents and we have to work with them. So this JSNA, we've done a lot of work to make this as resident centric as we could. And what we'd like to do is to make sure that all the work and literature that goes out to the public to get them on board to work with us to improve their oral health is accessible, easy to understand, appropriate reading level, for example. We'd also like to sustain Leicestershire County Council's oral health improvement team. So they do a lot of great work around supervised toothbrushing. They're also supporting with community fluoride varnish commissioning at the moment. And we'd like to consider increasing levels of fluoridisation across Leicestershire. So to help keep us accountable for this work, we've got a proposed governance structure. We don't quite have a logo yet, hence you've got a tooth right now. However, what we'd like to do is using our DMT colleagues to check and challenge our work as we go, feed directly into the Health and Wellbeing Board with your permission, and keep giving you regular updates on how we're going with this work. We'd also like to pull back together our task and finish working group, which span the integrated care system, and that would form that JSNA working group for Leicestershire. So it'd be a Leicestershire-centric focus with residents at the very heart of it. So really appreciate your time today. Thank you for listening. I'm happy to answer any questions.
Thank you. That was really clear, Luke, and I think there's some quite sad details in there, especially about children age 3 having teeth taken out, etc. I really am shocked by that. Christine Ratford.
Yeah, I homed in on, because I'm in charge of the adults section, is about the concerns of the care homes. I would imagine you are aware that we have teams that go into care homes to check. Are you working with them to make sure that they might discuss with the care homes staff about the oral part and that? And I am also aware that if you've got bad teeth, it doesn't help your health, does it? So I'm not quite sure how we can home in on that, because children like to eat sweets, and it's Halloween tonight, and there'll be a lot of sweets being handed out. So it's very, very, very difficult. But mine was just the home, the home care, really.
Absolutely. So we began to work with our infection prevention colleagues and adult social care colleagues. They're also part of writing this JSNA with us. We have a pilot that we're hoping to get up and running via the local dental committee in Charnwood to specifically try and understand what we class as best practice and make sure what we're going to do would work effectively. And then we'd hope to try and see what we can do to have a sustainable offer out to care homes via our oral health team and infection prevention colleagues. In relation to the comments around it being difficult for trying to support children's oral health, absolutely, particularly, but there is some really good work going on around supervised toothbrushing as well across Leicestershire, and they're able to get some really good education to parents, and we've been able to show some good results. So from our perspective, we're just trying to amplify that good work as much as we can. So yeah, but thank you for your questions.
Of living as it is, toothpaste quite expensive actually, isn't it? For some of the ones that my granddaughter doesn't like peppermint, so you have to pay quite a lot more to get toothpaste that she liked. And I know that's a silly thing, but if they like the flavour, they might clean the teeth.
Yeah. Yeah. Thank you for the presentation and the report. I thought it was really, really important for us to consider it in the round. I think, particularly Mrs. Radford's point about engaging with the teams that are going into care homes, the infection prevention control teams in hospital as well. We've got a system-wide IPC group that we might ask them to consider this from a hospital perspective as well. But I was kind of wondering whether or not we can support this in a way around type of a making every contact count approach, and really supporting general practice, community pharmacists to have those conversations with the public whenever they have those contacts with them, to try and raise the profile of it, because you're right, you know, the access issues are some of our real challenging thing, our most challenging issue. Whilst we're doing that, if we can kind of piggyback this on top of other messages that we're trying to get out, I think it'd be really helpful. Happy to support that if you need some inroads into the ICB.
Mike, would you like to come in?
Yeah, so a couple of points. One similar to Caroline's, which was, I think if Health and Wellbeing Board goes, yeah, we're up for a task and finish group. Is there anybody, not there's anybody in particular, it's obviously a group of people you worked with, but you know, are there places you'd like to reach out into? Because I know we do what we can around oral health promotion, but that kind of making every contact counts approach, building it into pathways across the NHS, district councils, ourselves, you know, there's probably more we can do to kind of raise awareness, subject to resources. One. That also then dovetails into what reach have we got into dentistry commissioning, and whether there's any sort of thing we can do around the units thing that's imaginative that might address the access bit. And then I suppose the big one for Health and Wellbeing Board at the end is you mentioned right at the end fluoridation. And in the context of cost of living crisis and cost of fluoride toothpaste and influences on children's health, I mean, it's a bit of an elephant in the room for me, is to what extent would the Health and Wellbeing Board support fluoridating water supplies? I mean, it's a governmental responsibility now, it's not down to local authority, but I find it hard to have a JSNA about oral health without triggering some kind of debate about fluoridation.
Yeah, thank you. Just a couple of points. I think just on the dental checks for children in care, I think it's gone up now. So I think we're about 66%, which is really positive. So the issue around dental checks for children in care, I think, is more of a capacity and access issue. And I'm just going to make a comment about children's oral hygiene generally, but it would worry me that we're not hitting 100%, because those children are in our care and we are the people who are responsible for making sure they access it. So I think there's something for us as a board around how confident are we that there is good access to dental care, because those children have got the support to access that care. So why are we not at 100% for dental checks? So I think that is something that we've got, is a question for us as a board about why on earth are all of our children in care just not having that access. The wider issue around children and children's dental health is a concern. And again, there's something about the availability of provision for any of our children to access. But I also think there's something around the ability of families to be able to engage in something that they may not consider as important, which then points, I think, to, important alongside all of the other things that families have got to deal with. And I think it then points to Mike's point about, so my worry is with the cost of living, with all of the other challenges families have, taking their child to the dentist or understanding the importance of taking their child to a dentist isn't really there. So therefore, as a strategic partnership, what can we do to influence it? So, I think we need to quite rapidly think about fluoride varnish or the putting fluoride in water issue, because I don't think this is an area that families will prioritise over being able to afford to feed their children or get their children to school. And therefore, what is it that we need to do? Because I think the impact of dental issues for children is probably greater than we kind of consider in terms of social health, everything as well. So it would be an area I'd urge us to really start looking into around what can we do, rather than continuing to seek to get parents to kind of understand the importance of dentistry, because I'm not sure we're going to be successful alongside other things.
Yes, Mika.
Thanks, Chair, and thanks for the presentation. It was really good with a lot of good statistics. I guess my question, I guess others have kind of already asked in one way or another. I guess what my question is obviously regarding the access in seeing a dentist, and you mentioned, there's training dentists, therapists, and attracting overseas dentists. So are we saying that actually we are short of dentists, or are we saying, and the elephant in the room is, do we find actually a lot of NHS dentists have handed their contract back in and going private? And is that why access has dropped? And then that leads me on to, if that is the case, then obviously the cost of living crisis will price people out. So I know there's a lack of access, and you have put down the recommendations. I guess my question is in terms of, you know, the NHS payment for UDI. Do we know when all of these things will be addressed by NHS England in terms of, as you said, fairer payments for, I'd probably say not completed dental care, but complicated dental care, because simple work and the UDI payment for simple dental treatment is probably similar to complex root canals and stuff along those lines. And that's probably why dentists are choosing not to take on or hand back NHS contracts. So I think there's multiple things here at play. So certainly we probably need to look at all of these. And I guess that leads me on to my final point, which is, yes, the recommendations are there, but do we know when these things will actually come into place?
So in terms of the dental reform, I believe some of it began in April 2022 in terms of fairer payments. I think your assessment is accurate in terms of it's both. It's that we are short within the dental workforce of actual trained professionals for dentistry. We're also struggling to recruit people. So I understand from our task and finish groups that during the pandemic, we had an exodus of staff. I've been unable to obtain an answer as into how quickly these reforms will happen. That's why one of the reasons that we didn't want to sort of duck it within a recommendation, we wanted to still do what we could locally, because it does sit within NHS England or commissioners to, Integrated Care Board to look at things like dental access, which we can support them with. There's certain examples, forgive me, it's detailed in the JSNA, I believe it's either 16 or 19%, for example, of less dentists in North West Leicestershire. So we know there's certainly an issue. We know some of the reforms are already filtered down, but we may be looking at a few years before we see things return back to normal. I think it's something interesting to mention that during the task and finish groups, one of the things that kept coming back was that this was a problem prior to the pandemic, and the pandemic pretty much accelerated it, unfortunately. Apologies if that's not like the most robust answer, but we can certainly go away and try and get more answers on that.
Thanks, Chair. No, I mean, the reason why I asked is obviously these are quite obvious things that people have probably seen on the news, and we as, you know, well, certainly me as a healthcare professional will know, because this is what's happening in all aspects of healthcare. I guess it's always good to have these recommendations and plans in place, but again, a lot of the time there's got to be resources which needs to be injected in by, I guess, NHS England. And if there's reforms, you know, that are, you know, going to happen in a couple of years, I guess what I'm saying is then what are we supposed to do in the meantime? Because these are kids without good dental health care, which is then going to have subsequent problems in a couple of years down the line. These are adults, care home patients, you know. I guess it's, you know, and it's probably out of anyone here's hands. So I'm hoping Caroline can have an answer.
Yeah, thanks, Nicola. I think there is, as has been described, we need the national reform to take place. There needs to be something in terms of the contract, and we've seen dentists leave hand over fist over the last probably 5-10 years. So it's about doing it at all different levels. I think the work that's been described through the JSNA and the recommendations going forward is in terms of the prevention stuff that we can do. The ICB needs to think about how we can use the funding that we've already got to use it in a way to try and attract people back to it. Take the people plan, what can we do innovatively across the workforce to think differently, and then inform the national approach to the contract. I don't think it's a kind of a one size fits all. I think we've got to attack it at all those different levels and make sure that we're putting consistent pressure upwards, but also using the data that we've got through the JSNA to make sure that our local plans from an access perspective are built based on managing health inequity in the way that we need to do. So where we have got dentists, are we able to make sure that that the impact of those dentists in place is having the best outcome for our population?
Thank you, Michelle.
Thank you. I thought the presentation was really good, really insightful. I'm interested. So we know there are the wider national challenges and needs, but that doesn't take away that immediate need that we have in our communities right now. And I was interested in the task and finish group that you've referred to, or groups that you referred to, and I guess looking for a bit more understanding of the representation on there. So I'm thinking about some of those partners that might be interacting with some of our most vulnerable residents that perhaps not part of those groups that could get messages to people. So for example, housing providers and landlords that can get messages to tenants. And then we know that we'll have food bank providers across the county, although, we don't want to accept food poverty as the norm, it is a reality right now. And I just wonder how partners such as that might be engaged, with donations of toothpaste and toothbrushes. Is there anything that can be done to address local need? And are those partners naturally part of those conversations already, or could they be in the future?
Yeah, so we were really fortunate with the Task and Finish group. We did have a really diverse bunch of professionals. That did include some food insecurity or food poverty professionals on the calls as well. We want to grow that Task and Finish group through this work as well. We envisage that it may steer less away from some of the more senior colleagues of ours and be more sort of like operational, more junior colleagues to make things happen on the ground. But one of the things we're really focused on with this is getting that sort of strategic footing in place, and then taking that group forward and making it as big as it can be, but still ultimately effective. But yeah, we did have a really good diverse group of people. We also were able to give out a significant amount of oral health packs containing toothpaste, toothbrushes, and that was distributed across the Fair Share network, across all food banks. And we're currently working on distributing oral health packs for our unaccompanied asylum seekers, because we found a particular health concern within that group that was unequal when you compare it to other groups. So we're doing a lot of work around that as well, and making sure that our data is good enough to respond effectively.
I think it's really important we have this group going, and we have the right people around the table. I think we've got to be taking action on this locally. We can't really wait until the dentists are trained up or whatever. We've got to, do the best with what we've got. I think it's important that partners come together and view the social determinant health drivers going forward, but looking at it through a system-wide lens, but actually having the place perspective on it. And that way we can then hopefully get things moving on this. There's some really serious issues in here, and I know you'll probably have seen from my position statement that the Leicestershire Dental Committee had written to me and about procurement, for example, in dentistry. So I think, and that's going to go to the Health Overview and Scrutiny Committee. But I think there's lots of areas within this we can't just solve here, but everybody in the system is going to have to be looking at this and pulling together, I think. Thank you. Thanks for the presentation. Okay, so we've been asked to support the findings and the recommendations of the Oral Health Joint Strategic Needs Assessment chapter and approve the chapter for publication. And I think also the setting up of or bringing back the group to look at these things. Is everybody in agreement? Yeah, thank you very much. Thanks. We move on to item 10, which is Children and Families Partnership Plan, the progress update to the Health and Wellbeing Board, pages 169 to 200. This report is to present to the Health and Wellbeing Board a progress update on the delivery of the Best Start for Life priorities of the Joint Health and Wellbeing Strategy, which sits within Children and Families Partnership Plan 2021 to 23, and to present the report we have Ellie Lowe, Service Manager in the Children and Families Service. Thanks, Ellie. Oh, sorry, and Marla, sorry.
I'm just going to do a brief introduction while Ellie sets up the slides, and then Ellie will take it from there. So for the priority leads, we continue to work with partners and other stakeholders to deliver against the 5 priority action plans within our current Children and Families Partnership Plan. A review of that plan is currently being undertaken, and will be the updated, refreshed plan will be shared with the Health and Wellbeing Board shortly. For the purposes of this report, though, our updates will focus on the progress that's been made against two key spotlight areas. First, 1001 critical days, school readiness and family hubs. So these two areas of work align with the sub-themes of the Best Start for Life theme of the Joint Health Wellbeing Strategy plan. And they align particularly with the sub-themes of the first 1001 critical days, school readiness and preparing for life. I'm going to pass over to Ellie to take it from here.
Thank you. So as Marla has mentioned, we're going to have a particular focus on 1001 critical days. So I'll begin with that. So in our presentation, we're just going to share some of the key achievements from the last iteration of the plan. So some of the things that we have been focusing on are around workforce development. So 1001 critical days is obviously those important first 2 years of a child's life, and it's been really important to focus on the workforce to make sure that they have a good and sound understanding of the importance of 1001 critical days. So during the last 2 years, we have produced an e-learning module which has catered for county council staff, but that's also then being converted into multi-agency workshops, and that's being launched next week in the Festival of Learning, which has a focus on bumps to babies. Within the County Council, we've now had over 200 staff trained in understanding the 1001 critical days. We've also worked with FE colleges and also with the university, so for example, providing training to midwifery students. Communication plans have been really important as part of the work that we've done. So as well as making sure the workforce understands the importance of the first 2 years of baby's brain development, it's also obviously really important that we have that communication with families also. So we've had quite a focus on our social media campaigns with bi-monthly updates going out to families through social media from LPT, UHL and from the County Council. We have information available on the County Council websites. We have developed resources for families, and that includes written information, but also videos which families can access. And through our Children and Family Wellbeing Service at the County Council, we hold regular events twice a year to which we invite families in local communities to come and join with us and learn about 1001 critical days. So equally as important as working with the workforce, it's also working directly with families. Just some examples of the social media activity. So just some basic data of the number of people that we've managed to reach through social media. And also we have had quite significant media coverage during the events that we've done and through our media campaigns. And this is all now very much becoming business as usual across the services and something that we'll be continuing to do in the foreseeable future. So our next steps on 1001 critical days, as mentioned, business as usual, but also one of the things that I think it's important to say, although I'm presenting on 1001 critical days, school readiness and family hubs, these three things are very much interconnected, and our work on family hubs will be picking up some of this and producing further media campaigns. We have more online around workforce development, which I'll go on to as we talk about family hubs. In terms of school readiness, there's been a number of key achievements over the last couple of years. One of them is around developing our pathway of support. So just to go on to that, the diagram's probably terribly small for you. I'm very sorry about that, but it does give you some information about how the pathway of support is actually functioning. And one of the key things that's been happening has been the sharing of ASQ, which is Ages and Stages questionnaires, the sharing of data across health, local authority children and family wellbeing services, and also our early years colleagues. So we've been using that data both to identify children who may be in need of additional support because they haven't reached milestones, but also using it to identify early years settings who may benefit from some additional training or additional support in the setting because the data is indicating they have a higher number of children who are not reaching their milestones. So from the data, it's enabled us to, for example, put in OT support in early years settings and also provide support directly to children and families. Well, I think one of the really important things also is that we're able to track those children and make sure that they're not slipping between the gaps or falling in nets. So making sure that when they have been referred onwards to another service, that referral is picked up, the family is accessing the support that's available to them. Other things that we've done around school readiness, so letters go out now to all families 11 months before their child is due to start school, and they're also provided with leaflets and information about things that they can do in order to help their child to be ready to start school. There's also website-based resources for families on getting ready for school, to school top tips of things that families can be doing with their children. And I'm going to go on just to give you some information about the take-up of the free early years education entitlement, and also some information about communication and language training. So the data now that's in front of you is the results of the early years foundation stage profile. This is the 2023 data. It's showing that Leicestershire is performing well against national and regional averages, so slightly above in all areas apart from children who are in receipt of free school meals. But overall the picture is positive, because prior to the 2 years focus on this work, we were actually below the national averages, so some considerable improvement has been made. And just some information for you on the uptake of the free early education entitlement. Again, we are doing very well in Leicestershire with both 2-year-old and 3-year-old take-up. I'll just mention that summer 23 isn't a blip, it's just that by the summer term most children have turned 3, and that's why you're seeing 100% in the 3-year-olds for the summer term. So that is all going particularly well. Research tells us that it's really important for children to be attending quality early years provision. And we also know from that research that children who have attended early years provision tend to have much higher outcomes in education throughout their life. So it's really important that children are accessing the entitlement. In terms of communication and language, we have been providing universal and targeted training. There is training available across early years settings. We know that following COVID had a huge impact on children's development around communication and language skills. And we also understand that the home learning environment is really, really key. That can be more difficult to have an impact on. So obviously that is a strand of work for us, and it's something that's getting picked up again through family hubs to talk about home learning environment to families. But we are able to focus efforts with a high number of children attending early years settings to make sure those settings also have that shared understanding of the importance of early language and communication skills in very young children. The early years settings have been supported to access training sessions which meet their needs. So, for example, short 1-hour sessions on particular areas, and thematic materials have been shared with them. Some of the challenges that we have in this area of work, as you may be aware, the government's recently announced an expansion of childcare. This does present some challenges to Leicestershire, and probably to most local authority areas. I think in particular, Leicestershire has lost over 1,000 early years places since COVID, and that's a combination of difficulties around cost of living. There's a recruitment and retention crisis in the early years workforce, which unfortunately is similar across a lot of the health and social care sector. And so it will provide some challenges for providers and for the local authority to ensure that there is sufficient place to meet demand. Our next steps, as we move forward, we've been working on the development of a maternity and early years strategy for Leicestershire. This clearly meets some of the priorities of the Health and Wellbeing Board, so particularly looking at joined up and accessible services. What we've done with the development of this strategy is hold a number of partnership workshops where we have had colleagues from across the voluntary and community sector, from health, from local authority, from early years settings and from schools to work together to understand some of the issues that we can help to resolve through having a strategy and a plan attached to that strategy. One of the first things that became really apparent was the whole breadth of activity that there is around maternity and early years. And that presents a real difficulty for both strategic leads and also for operational staff to really get a grasp and understand what is going on across the county, but also across LLR, as some of these groups are across the sub-region. Just in this slide as an example of some of those groups that currently meet. And there is obviously some crossover. So some people will attend a lot of those groups and some of those groups will have some quite different membership. So the challenge, I think, for us is to map and understand all of the different bits of work that go on, but also what was coming out of our workshops was that for practitioners to have a really good grasp of the totality of the offer for families around maternity and early years provision is really, really challenging. And so again, through the Family Hubs work and our workforce development plan that will fall within this strategy, we'll be looking at how we enable practitioners and services right across the sector to support families and help them to make informed choices about the services they access. So on this slide, we have some of our aims around consistent and shared messages across all providers working in the 0 to 5 arena. In particular, we want to look at making sure the workforce has a shared understanding, and one of the things that we'll be exploring is around shared competencies and also the evidence base that we use across those services. We want to do more with data. Our learning from the use of the ASQ scores has helped us to see that data is a really important part of the puzzle. And so as a partnership, we want to look at how we can share our data to inform our decisions as we go forward. And we're also very keen to make sure there's meaningful engagement with communities. So across Leicester, Leicestershire and Rutland, there are arrangements in place for a maternity and neonatal panel. So we'll be drawing on that, but also working to engage communities to understand any barriers to accessing their services. And again, I'll pick that up under the Family Hubs update, which we're now at. So just a quick reminder for people about Family Hubs in Leicestershire. So Leicestershire County Council was one of 12 local authorities to receive just under £1 million of funding, and we received that money around 12 months ago. We have until September 2024 to deliver a transformation programme around Family Hubs. So the funding we have is different to, for example, Leicester City Council, who have accessed the money that was based on indices of deprivation and is about provision of services. The money that we have in the county is for the transformation programme and delivering the framework for Family Hubs. So Family Hubs, just to summarise, they're one-stop shops which families can use. They're for 0 to 19s or up to 25, where a young person has SEND needs. The hubs are a mixture of physical and virtual spaces. So we're building on the 20 buildings that we already have around the county as children and family wellbeing centres become family hubs. We're also working very closely with our partners in the library service, and we're developing hubs in libraries around the county as an alternative way for families to access information. The website is also an important part of what we're going to be doing. So some of the key achievements: in June this year, we held a partnership conference, which was really well attended with over 60 delegates attending. It was really good to get people together into a room and to be able to engage on this agenda and talk about the vision for Family Hubs across Leicestershire. Because as well as being about buildings and about a website, it's really about how we start to deliver more integrated services to support families, and that's really at the heart of Family Hubs. So it was a great opportunity to all come together and share that vision. I'm just going to play for you a very short video that just summarises some of the activity from the conference.
I'd like to welcome you to Leicestershire's first Family Hubs conference here in Kegworth in Leicestershire. Today we have invited a range of our strategic partners to celebrate with us the launch and the opening of our first Family Hubs across Leicestershire.
So we are delighted to have been awarded nearly £1 million from the government Family Hubs Transformation Form.
But 1.2 million children are estimated to be affected by parental conflict. And when I start to talk about the consequences of actually being in an environment where conflict is in evidence, we'll see the impact of that on children.
So the creation of Family Hubs in Leicestershire provides us with an amazing opportunity to come together as a partnership to review, to refocus and to realign the way we're delivering support to children, young people and families in the county.
An underpinning piece of work in our Family Hubs is the launch of our Relationships Matters commitment. So we've asked our partners and all the professionals across Leicestershire that work with us and work with families to sign up to our commitment to reducing conflict in family homes across Leicestershire. We've called this Relationship Matters in Leicestershire. We're going to be making sure that all our frontline staff and all our business support staff have an awareness of reducing parental conflict at home, so that this will reduce the impact this has on children in family homes.
You've already made the link here, and everybody's made the link between Family Hubs supporting families and reducing parental conflict. Many of the families that interact with us, whether it's supporting families, whether it's for Family Hubs, will actually come together like a Venn diagram, experiencing a variety of things, including parental conflict, but there might be the same families. So it's completely right that we're actually sharing this agenda across a range of agencies, across a range of approaches where we come into contact with families.
So today's conference is an opportunity for us to reflect on the strengths of the work that we already have across Leicestershire, as well as the start of a new, refreshed approach to our vision for how we will deliver services together for children, young people and their families.
Hopefully that gave you a flavour of the conference. Moving on, one of the things that we're required to do under Family Hubs is to publish the Start for Life offer. And this is a really important piece of work for us to do, because again, it's about communicating with the public about all of the elements that should be provided under Start for Life. And it was interesting listening to the previous presentation. Oral health is a part of what comes under Start for Life. There's a whole plethora of things. The challenge for us, and which we're excited to do, is to think about how we have that dialogue with families about their role that they have to play in creating home learning environments, in creating good conditions for their child to have best start in life. So community engagement is a big part of Family Hubs, and we've been really keen to work with sectors in the communities who we have identified as facing particular barriers to accessing services. So during our feasibility stage for preparing for Family Hubs and through our partnership working, two particular areas have been identified to need a closer focus. And the first is around access to maternity services among particular sections of the community. So in particular, women from Black, Asian and other minority groups who have, in Charnwood area in particular, experienced later booking in their pregnancies, which obviously can lead to some health risks. We've been working with our colleagues and commissioned a service which we've called Maternity Champions. It's been delivered by the Centre for Fun and Families in Loughborough. And what they've been doing is a lot of outreach work with communities, with community organisations and religious establishments to talk to people about access to services and what the barriers are and why perhaps people are later in their booking or not accessing maternity and early years services in those communities. And we've been then working alongside our volunteer service within Children and Family Wellbeing Service to recruit maternity champions from those communities. deliver training to them, and therefore then have a more sustainable project as we go forward, supporting communities to speak up for women in those communities. The learning that we've had from the project about the outreach we've done has been really interesting and useful, and something that we'll be sharing through our evaluation work. The second area that we're focusing on, and again reflecting on some of the discussion from your earlier presentations, is working with families from Gypsy and Traveller communities. So again, women in particular from Gypsy and Traveller communities have been identified as not engaging with maternity, with primary health care, or with early years services. So we're commissioning GATE, which is the Gypsy and Traveller Equalities Organisation, to do some work with those particular communities. And there's a group of Traveller women that we're working with to develop this specification. The work is due to start in November and will run through till September next year. So again, it's about understanding some of the barriers, but also looking at some of the anecdotal evidence we have coming from those communities. So for example, an increase in young Gypsy and Traveller women who are actually living outside of their communities and are often young parents and living alone. We're also very aware of mental health issues amongst the men in Gypsy and Traveller communities and high suicide rates, but also building on what works. So we know that people from Gypsy and Traveller communities will often access libraries for the free Wi-Fi and to be able to use computers. So thinking about how we use family hubs in libraries to reach out to families from those particular communities. As well as that targeted work, we've also been fortunate to employ 2 community engagement workers, and we've been reaching out to lots of different smaller organisations and communities. So we've done work over the summer with families, but we've also been talking to organisations such as the Rural Community Council, Leicestershire Mind, Memphis, Active Together. There's a whole host of organisations. We've been making connections to think about how we can work together to deliver family hubs. So, for example, one of our target areas is people living in rural areas who may also lack access to website and digital information. So we've been talking to the libraries about the mobile library bus that goes out and how we can use that to deliver information to communities. And similarly with the Rural Community Council, who take coffee vans out and share information that way. I've just included here, and I'm sorry it's very small, hopefully better in your packs, just some information about the buildings which are being launched as hubs and the libraries which are included. These will all be open by the end of March. Just to go back to reducing parental conflict, in the conference clip there was some information there about it. So to give you the background, the Department of Works and Pensions has been funding a national programme called Reducing Parental Conflict since, well, it's actually been running for about 10 years in some areas, but came to Leicestershire in 2018-2019. And initially it was about providing training to the broad workforce to understand the impact of parental conflict on children. When we talk about parental conflict, we're talking about frequent unresolved arguing in households, which can often mean a lot of shouting. They can often be circular arguments, and it can be very frightening for children to be present. The impact on children is very similar to those children who are living with domestic abuse. So in our first year, we did a lot of awareness training. Practitioners then told us that they didn't feel confident in talking to families about parental relationships. It felt very uncomfortable to ask about the quality of the relationship. So we commissioned a practitioner's toolkit, which provided them with resources and advice on how to tackle some difficult and sensitive subjects. We've now trained over 400 people across the broader early help partnership, so in health, in schools, GP practices, across social care, children and family wellbeing service, and we continue to roll that training out. We've taken on a train-the-trainer model, so again we have some sustainability beyond the funded period. We have a core development group which sits under the Early Help Partnership, which is a subgroup of the Children and Families Partnership, and together they've produced a document which is called Relationships Matter in Leicestershire, and that sets out the ambition and the aims and the vision of our partnership group in reducing parental conflict and putting relational practice at the heart of what we do. Just move on. So our challenges for family hubs. Clearly we have a challenge in that the funding period is quite brief. The majority of our funding has to be spent by March 2024, and we have some ability to carry over a small amount of funding to September 2024. So it's a very short timescale in which to achieve transformational change. And I think beyond the funded period, there will be some challenges for us to maintain the momentum which we've created without funded posts dedicated to this particular piece of work. But Family Hubs is a key element of the wider early help system, and so we hope we will be able to continue driving this work forward through the Early Help Partnership Group and helping everybody to understand that early help is the responsibility of all of our partners, whether that's voluntary sector, whether it's statutory organisations. We're all responsible for delivering early help, and it's not purely about a referral to a particular service. Our next steps for Family Hubs. So we have been doing a lot of training across front of house staff, I'll refer to them as, so reception staff, people who work in libraries. We have been providing training on making every contact counts, on trauma-informed practice, awareness of parental conflict, and also awareness of adult mental health difficulties and mental health first aid. And that's something that we look to continue. So we have made that offer across the partnership to district councils and to any other organisation who would find that helpful. We also have begun work on an early help competency framework that will be sitting across LLR, because a lot of us are working with partners obviously across the sub-region. The competency framework will be looking at the key elements and a graduated response for the early help workforce. So obviously at the lowest level, looking at awareness of trauma-informed practice, making every contact count and reducing parental conflict, but through to more specialist practitioners and the different levels of training and skill that they will need. We do have the Family Hubs website under development. There is currently a holding page and it will be launched hopefully by the end of December. It's a partnership website which is for parents and families, it's for young people, and it's for professionals. So some of the work that we'll be doing on the Family Hubs website will include self-help resources for families. So those families who are able to help themselves and not need to rely on a service to provide support to them will be able to access videos and other resources on there on common issues such as parenting and behaviour management. There's also areas for professionals. So in our workforce development work, we've pledged to support induction of new staff to the early help workforce by having short videos from different organisations explaining their roles and remit. Okay. And then just finally, we also really pleased that we are working with Quorum, which is a national organisation, and they're our partners in a process evaluation of our work on Family Hubs. We're developing a theory of change across the partnership for Family Hubs, and in November we have a workshop which we're very much looking forward to, and there's lots of opportunities right across the partnership for people to get involved with that theory of change workshop, but also in all the other work we're doing around developing the Family Hubs website, our community engagement work. Yeah, so just a lot of opportunities to get involved. Thank you, that's the end of the presentation.
Thank you, Ellie. That was really helpful and very clear, and a lot of really good work going on. And it's great to have an agenda item that is for the Children and Families Partnership and hearing how it's delivering against the Joint Health and Wellbeing strategies priorities for that life course. So thank you. Does anyone have any questions or points? Do you want to speak, Deborah?
I don't think I can add anything to what Ellie's already done. So yeah, no, it's a really good presentation, and yeah, we'd just be grateful if people could share Family Hubs around their organisations, please, because it really is an important place where people can go. So just my plea is to just share it, please.
I had got a question on sustainability because you mentioned about it being grant funded. Do you have any plans going forward as yet on that score?
So as much as possible in everything we're doing, we're building sustainability in. So for example, the Maternity Champions project moves over to our volunteer programme within Children and Family Wellbeing. The Family Hub's website will obviously need to be maintained. We're paying forward for the technical aspects of it, but we'll also be building in support as our part of our business as usual, which means recycling existing funding. But we feel that that's a priority. We feel it's something that's been missing from the Early Help Partnership, to have a source of information for families and professionals. So we'll prioritise that going forward. So as much as possible, we've built sustainability into everything that we're doing.
Thanks. And the other thing I just want to say, you mentioned about the refresh of the Children and Families Partnership Plan. And I just wondered if and the early help strategy also. So will there be links to the JHWS?
Yes, they absolutely will align. In essence, the key areas of focus, so those 5 priorities of the plan, will remain the same. The Children and Families Partnership have undertaken a refresh, and they have identified that those are still key priority areas, and those will link directly with the Joint Health and Wellbeing Strategy delivery plan. It's the particular actions that now need to be updated because we're 3 years into the current plan. So it's those actions that are shifting.
Thank you. I think, first of all, an amazing amount of progress in a relatively short period of time. So really good to see. But I was really interested in the parental conflict point. There's lots of awareness around that, lots of training across teams and partners. Just wondered if there are any trends emerging, or if there were any trends emerging around reasons for parental conflict. For example, are there any links to cost of living pressures and that kind of thing? How are they sort of being fed into the relevant discussions to inform other pieces of work?
Yeah, I mean, very much the evidence suggests that it is related to cost of living. We saw a huge increase in the number of referrals to children and family wellbeing after COVID. And unfortunately, a lot of those do relate to parental conflict. And we also understand the impact that has, particularly on children and young people's mental health, because they don't feel safe at home. It doesn't feel like a safe environment. So we see the links there through to baby brain development, but also children going missing from home because they're choosing to leave the home environment. So yes, that's very much been a focus of the work. But the other area that we're focused on currently is work with the police around the categorisation of call-outs to domestic incidents, which tend to be labelled as domestic abuse. We've produced evidence which we've shared with the police that around 45% of the calls for domestic abuse are actually about parental conflict. And so that's some work we're doing to both look at training across the police force, but also look at how they're able to record the accuracy of the call outs that they're having. It's important for us that we get that right, because for families who are arguing, to then be labelled with domestic abuse can be very challenging. It can be very difficult for them to access help because they don't recognise themselves as being in an abusive situation. It's just Saturday night arguing, which unfortunately often happens. So getting that right with the police is really important, because then we can offer the right service to families when the right language is being used. And we've done a lot of work with families about what the right language is. They do want us to talk about arguing. We're using parental conflict because that's part of the national programme branding. But when we're talking to families, we're very much talking about arguments and how to argue better.
Okay, anybody else? Right, we're obviously noting the progress in the delivery of the strategies that sit within the Children and Families Partnership plans. So thank you very much. It's been really interesting to hear, and wish you well on everything else you're doing at the moment. Thank you. Okay. The next item is Leicestershire and Rutland Safeguarding Adults Board Annual Report 22 to 23, and the Business Plan 23 to 25, pages 201 to 238. The purpose of the report is to present to the Health and Wellbeing Board the annual report of the Leicestershire. Oh, I just told you all of that. Sorry, I'm miles away. John Wilson, Director of Adults and Social Care, Adults and Communities, is unwell, unfortunately, so hasn't been able to join us. So if we can just take the report as read, and are we happy to note the key points of relevance relating to health and wellbeing? Yes, thank you. On to item 12, Leicestershire and Rutland Safeguarding Children's Partnership Annual Report 2022-23 and Business Plan 23-25, pages 239 to 282. And this report is being presented by Jane Moore, Director of Children and Family Services. Thanks, Jane.
Thank you, Chair. So as set out, this report is presenting both the annual report for last year and also the business plan for this year. And I'm presenting on behalf of all of the safeguarding partners today. The framework, the legislative framework for this, we've set out in paragraphs 5 to 12. I won't go over it in detail, but it essentially sets out why we produced a Children's Safeguarding Partnership annual report and business plan as well. So just by way of background, the annual report is set out to assess the impact of the work that was undertaken by the Safeguarding Partnership on outcomes for children in Leicestershire and Rutland over the period of 22-23, and specifically it looks at how we evaluate the performance against these priorities that was set out in the business plan for that year. The report also outlines the learning, the assurance and the training and improvement activity that's taken place by the partnership and its partners, and the impact that this has had on safeguarding children in those two areas. Key messages from the report specifically are around the fact that the partner organisations, workers and managers have worked well together to safeguard children, to identify needs and also areas for improvement. The partnership has continued to work hard to respond to some of those emerging issues that we've identified through various reviews, such as safeguarding babies across the area. With the partnership has continued that focus around child mental and emotional health and wellbeing, keeping adolescents safe and supporting safe adolescents, and also continuing to understand how well the partnership works to safeguard children from diverse backgrounds as well. We've kept a real focus on improving engagement with schools, and particularly around some of those independent schools as well, and also considered how we continue to respond to some of the national developments relating to safeguarding children across the country as well. In relation to next year's business plan, the plan sets out the key deliverables and activities that are required to deliver the partnership's priorities for the forthcoming 2 years. The plan is shared with the City Safeguarding Partnership as well. There are two separate boards, but the plan sits across both of the boards. And you can see, and we've set out completely in Appendix B, what the priorities are for the forthcoming year. We've actually retained 5 of the priorities from this year because they're still important and as necessary for us to work on. So there are 6 priorities within the business plan, continuing to focus around safeguarding babies, child mental health and emotional wellbeing, keeping adolescents safe, and safeguarding children from diverse backgrounds, and that continued focus around effective safeguarding of children in independent schools, but also out of school settings as well. And then the additional one we've added now is around transitional safeguarding and how the partnership supports that alongside the Safeguarding Adults Board as well. The annual report we have consulted, and within the annual report you'll be able to see a summary of the consultation and engagement work that was carried out with our children and young people across Leicester, Leicestershire and Rutland, and we've included a number of quotes in the report as well from our children. All of the members of the partnership have had the opportunity to contribute, and prior to the publication the report was considered by the County Council's Children, Families, Overview and Scrutiny and Cabinet, and both groups welcome the report. So I'll leave it there, Chair, for any further questions. Thank you.
Thank you. Are there any questions? No. Thank you, Jane, for the report, and thanks to the partnership for the work they do. It's not easy. So we're being asked to note the report and the business plan. So you're all happy? Yes, thank you. We're now on to the annual report of the Director of Public Health, Leicestershire's Health, what the Health and Wellbeing Board's dashboard tells us. and it's pages 283 to 314, and it will be presented by Mike Sands, Director of Public Health.
Yeah, thank you, Chair, and thank you those who are able to stay. Whilst everybody else has gone, never mind. Right, so this is my annual report. It's been a while, so I have a statutory duty to produce an annual report, but I haven't actually done one since 2019, so welcome to my 4-yearly annual report, which doesn't make any sense, for hopefully fairly obvious reasons, in as much as COVID wiped out 2020 and 2021, and probably should have done one last year, but just ran out of room in terms of catching up. So I've tried to, well, I have. So I thought it's time to get one out there. And I've gone back to kind of first base in terms of what is the purpose of an annual report from the Director of Public Health, which is to say something about the health of the population. Now, we've heard a lot today about inequalities and, you know, a bit of a spoiler alert. There's obviously much I could say. This is about the overall health of the population. Next year, you can probably guess I want to dig into some of the subgroup populations, because to some extent, that's where the richness of the stuff we've been talking about today will come from. But I didn't want to lose the opportunity to say something about, all right, we've got through COVID. What are the big drivers for health in our population? How are we doing? So I'm glad Victoria's hung around, because I did email her and went, DPH annual report's back on the agenda. Have we got a dashboard that tells us something about a broad brush of the population health? And very properly, Victoria pointed out, was like, well, that's the Health and Wellbeing Board dashboard. So I have fairly unashamedly ripped off what is the Health and Wellbeing Board dashboard, which, as it says in the report, lists over 100 indicators split by the themes that are in our strategy. So the life course approach and the cross-cutting themes. And it gives a level of performance against all those indicators where we've got data available, partly how we stand compared to the national average, and then where we stand compared to the buckets of 16 other comparator authorities. And again, I think in a previous presentation we talked about, I think it was Luke, talked about those authorities that are similar to ours in terms of demography. So it gives a bit of relative performance in there. In terms, so hopefully, you know, it's readable, and you know, hopefully you've read through it. In terms of kind of takeaway messages for me, as you would expect, and maybe not a surprise given the relative level of affluence that the demography chapter of the JSA picked out, Leicestershire is a relatively healthy place, and we've got far more indicators where overall our health is better than average, and some actually leading performance as well than there is the bad ones. So there's always that kind of reassurance. I made a few probably more specific recommendations, which are almost notes to myself, because I think there are some big ones in there that, from the point of view of the work of the Public Health Department and working with partners, kind of need to reevaluate. So physical activity is one, particularly around the percentage of people doing the CMO recommended guidelines. I could have chosen other indicators outside the Health and Wellbeing Health and Wellbeing Board dashboard, which are more focused on making the inactive active, and probably could have celebrated a fairly good performance against those. But in terms of what we put in the Health and Wellbeing dashboard around, are we getting the most people active? The answer is we're probably not doing as well as our relative level of affluence and deprivation would suggest. And the other big one for me was around diet. So again, need to reconsider our whole approach within public health to some of the stuff around healthy diet, particularly around 5 a day. And there's sundry bits on there which, if not necessarily totally within my control, you know, that ever renewed focus on emissions of PM 2.5 and its effect on air quality is definitely one. So that's it. So I mean, there's other recommendations in there. As I say, really, it was a chance for me to sort of reflect on the work of the department and think about what we need to do in the future to address the kind of really big hitters. There's probably a lot of stuff in there for people around the Health and Wellbeing Board to take away and digest themselves, because there will be things, I'm looking across to Jane, you know, really worthwhile just looking at the best start for life and just thinking, what does the indicator set tell us, which we can then follow through next year in terms of the inequality stuff. So as always, I think the annual report also says it's a chance for advocacy. So I can make recommendations for myself and for others, but really it's to generate a discussion either here, might be lacking given time, but it does go through scrutiny and full council and the cabinet. And of course, there's always a willingness from me to come out to your own respective organisations and present and do it in detail, just to see if it helps spark a few thoughts around actions that may be taken. So I'll rest there. Thank you very much.
Thanks, Mike. Has anybody got any questions? Yes, Caroline.
Thanks, Mike. It's more to take you up on your offer, I think. I think we need to really ensure that we've got this fully distributed and understood across the health perspective. And it's whether or not we might do something at ICP with the 3 annual reports to look at them collectively, so that we get that really good rounded reflection, so that we can think about how that impacts on what we're doing together, and as well as what we're doing separately.
Yes, that's a really good point, actually, Caroline. So the data will be there, whether it's in an annual report or not. I haven't done one for Rutland yet. You can probably guess what that would look like. Cities, obviously, Ivan, in his last one, chose to do one that was more about reflection on COVID, and he went topic-based. I guess in my mind, I mean, I've done it myself over the years. I've done topic-based reports, whereas I'm thinking, no, I want to go back to the basis of tell a picture about the health of the population. Doesn't mean that there won't be equivalent indicators for the city, which if we wanted to do an ICP and said, what do we think overall is fair enough? Sure, it would generate the same points I've made. People might debate if we got the right indicators, or they might say, yeah, but within, and I, it's like I would say for Leicester, within the vanilla that is Leicestershire, we do need to think about the subgroup analysis. But again, I think the major point is maybe just trying to get an ICP conversation about how we're doing, what are we doing in terms of overall health. But yeah, it'd be good.
Okay, thanks. I can't see anybody else wanting to ask any other questions. So we're being asked to note the report, note the recommendations in the report, setting out priorities for the Public Health Department, and consider its own priorities for the medium term in the light of the data in the report. So we're all agreed? Thank you.
Question from me.
Oh, sorry. Question from Mike.
Actually, it's a question for Rosemary. Remind me, when's it published? Like, is it, because it's in the public domain now, the annual report, does it exist from today, or does it exist when it goes to full council?
It's published with these papers, so it exists online from now and free to share, because it only goes up to full council and other bodies for noting anyway. It is your report, you own it. And we will also publish it on Leicestershire or LSR online.
Correct.
Thank you. So the date of the next meeting will be the 7th of December, and that's going to be a development session on mental health. I think that's quite important if we can encourage people to come along and get round the table on that. And then the next meeting of the board will be Thursday, the 29th of February. I have no urgent items, so that concludes the meeting, and thank you all for attending, and those who have stayed to the end. Thank you very much. Just to inform you before, I wasn't sure if I was allowed to tell you or not, but just to congratulate Caroline Trevivick for being promoted to interim chief exec of the ICB. So she will be taking place of Andy Williams as he retires. So congratulations.